Hi, welcome back. Today I'm going to walk you through cardiology SATA questions on ECG topic. So I'm going to discuss regarding the lethal cardiac dysarrhythmias. So here what we should know is we should not by heart the ECG. We should only remember how and what type of action has to be done during such emergency conditions when we see such lethal dysarrhythmias in the patients. So we need to just remember what action has to be taken for certain types of dysarrhythmias. So here I am going to walk you through the life-threatening dysarrhythmias. I am going to explain with a scenario, and I am going to clear the concepts and the strategies how we are going to answer the ECG type of questions. The first scenario, it's about the ventricular fibrillation. Here it is a SATA type of question. So the question says a client suddenly becomes unresponsive. ECG shows chaotic irregular waves with no identifiable QRS. Which action should the nurse perform? So this is the ECG which is given for ventricular fibrillation. So as I said, ventricular fibrillation is a type of dysarrhythmia, which is a type of dysarrhythmia from the ventricles, where there is no active cardiac output being produced by the ventricles. So there is a quivering movement of the ventricle chambers. So what are the options we are going to see? The options are initiate CPR, prepare for immediate defibrillation, apply oxygen via non-breather mask, administer epinephrine as per SCLS protocol. Now obtain a 12-lead ECG before interventions. So these are the options. ECG, that is a ventricular fibrillation, what exactly we have to do? Correct answers are number 1, number 2 and number 4. That is initiate CPR. It is correct. As I said, there is no effective cardiac output being produced. So we should initiate the CPR immediately and prepare the immediate defibrillation. As there is no effective cardiac output and a heart rate being produced, so we need to prepare for CPR and along with immediate defibrillation. Administration of epinephrine, that is adrenaline, is also most important as per the ACLS guidelines. And what are the wrong options are option number 3 and 5, where we are not going to give oxygen at this particular point of time, but we are going to initiate the CPR first. And of course oxygen is also important. First we are going to initiate the CPR, side by we are going to give oxygen, and 12-lead ECG we are not going to take time in taking a 12-lead ECG at this particular point of time. Once we know it is already a condition of atrial ventricular fibrillation, so we need to act at the priority. So we are going to question number 2, that is pulseless ventricular tachycardia. So here the scenario is the ECG shows wide complex tachycardia at 180 beats per minute. So the client is unresponsive and pulseless. So which actions are appropriate? It is a SATA type of questions. So this is the ECG which shows that ventricular tachycardia with a heart rate of 180 beats per minute. So the options here are begin CPR, defibrillate immediately, administer amiodarone after shock, perform synchronized cardioversion, and check the blood pressure first. So the correct options here are 1, 2 and 3. Begin CPR, that is most important because it is already there is no pulse, but the heart rate is showing in the monitor is 180. So we need to initiate the CPR and we need to defibrillate the patient immediately because there is no cardiac output. As I said earlier, it is a pulseless VT, and administer amiodarone. Once the shock is given, the patient is settled, still the patient is having a higher rate, then we can give a medication, amiodarone, antiarrhythmic medications. So the rest options are cardioversion, check BP. Cardioversion is given in pulse full VT, where the patient is a bit stable condition. It is a planned procedure. So this option is not appropriate for this particular type of question, and BP check can be done once the initial management has been done. Okay, now I am going to take you into the third question. It is about the ventricular tachycardia with pulse. So the patient here is unstable. So what has to be done? The client with VT has hypotension and chest pain, and he has an altered level of consciousness. So which interventions are indicated? It is a SATA type of question. So this is the particular ventricular tachycardia with the pulse, and so the patient is unstable. Now we can see the options. The option says synchronized cardioversion A, and number 2 is sedate if time permits, and number 3 is defibrillation, and number 4 is oxygen administration, and number 5 is continuous ECG monitoring. So here the options 1, 2, 4 and 5 are correct, where synchronization cardioversion is essential because the patient is having pulse full VT, but he is a bit unstable, but the cardioversion can be tried. And sedation is required because we are giving a shock, and sedation is given if the time is permitting to give so. And we have to give oxygen because it is once we are giving sedation, there might be compromise in airway. So we need to plan the procedure. We need to give oxygen also, and we need to keep the patient in continuous monitoring because it's like a synchronized cardioversion. It is a procedure where we need to revert this pulseful VT into a normal sinus rhythm or another rhythm which is patient is coming back to normal. So the continuous ECG monitoring has to be done to check with the patient condition whether the ECG is reverted or not. Okay. Next question we are going to see is about the stable ventricular tachycardia. The patient is stable here. The client has VT, ventricular tachycardia, and he is having a BP of 130/80. He is alert and the pulse is present. Which order should the nurse anticipate? What are the orders the nurse should anticipate? Here is the ECG which is given here for this pulse full VT. So the options here are IV amiodarone, and second one is continuous cardiac monitoring, immediate defibrillation, check potassium level, prepare for pacing. So the correct answer here are IV amiodarone is given because the patient's heart rate is quite high and the patient is bit stable here. So antiarrhythmic medications can be tried, and the patient should be on continuous cardiac monitoring as we are going to monitor this patient. She should not go into any other lethal arrhythmias, dysarrhythmias. So, and we have to check the potassium level. That is also essential because sometimes hypokalemia may also cause dysarrhythmia. So, we need to have a check on potassium. And the wrong options here are 3 and 5, where shock is not given. If it is a pulseless VT, then the shock is given. And pacing is not required as it is not indicating any heart block over here. So, pacing is not required if the patient is stable. This is another thing which is given in the question. So, next question we are going through is regarding the complete heart block. So, here they are stating about third degree heart block. So, here the patient is having heart rate of 28 and having severe hypotension. He is having dizziness. ECG shows no relationship between the P and the QRS complex. Which actions are appropriate? It is a SATA type of question. So, here we need to prepare for transcutaneous placing. Option number 1. Option number 2 is administer atropine. And option number 3 is apply oxygen. Option number 4 is continuous BP monitoring. Option number 5 is immediate defibrillation. So, the correct options here are 1, 3 and 4. That is, prepare for transcutaneous pacing, apply oxygen and continuous BP monitoring. Because atropine cannot be given in this condition because already the patient is having third degree heart block. It is some condition where the patient is having some issues with the conduction system of the heart. So, here we should give oxygen And here the correct options are prepare for transcutaneous pacing because the heart rate is very low, that is 28 beats per minute. It is most essential that because with this 28 beats per minute there is no effective cardiac output for the patient. So if you are providing a transcutaneous pacing, it will help. The transcutaneous pacing is most important to revert the patient back and to maintain his physiological condition. And we need to apply oxygen as he is having very low heart rate, and we need to secure the airway. This is also a good option. And continuous BP monitoring has to be done because as we are giving a pacing from external source, and as such the BP heart rate of the patient is very less, so we need to monitor a continuous BP monitoring. Atropine cannot be given this in third degree heart block because it is ineffective, because there is some problem with the conduction system of the heart. And defibrillation is again inappropriate because there is some heart rate with the patient. If there is no heart rate or absolute absent of heart rate, then we can opt for defibrillation. This is the wrong option. Next we are going into according to the sixth question, that is Mobitz type 2, that is second degree heart block. As I said earlier, Mobitz type 2 is a type of heart block where there is constant PR prolongation. That is, the PR prolongation is constant. It is constant in each beat until there is a miss of P wave followed by a QRS, until there is a miss of the P wave. So, type 2, there is a constant PR interval and before there is a miss of QRS complex. So, it happens where we cannot have an effective cardiac output. So, this is also a lethal dysarrhythmia. So, now we can see the options. The options here are prepare for pacemaker insertion, continuous cardiac monitoring, number 2. Number 3 is administer atropine as a definitive treatment. And option 4 is notify the provider immediately. And option 5 is observe without intervention. So the correct options are 1, 2 and 4. That is prepare for pacemaker insertion. Yes, it is correct. Next one is continuous cardiac monitoring. This is also a good option. And administer atropine as definitive treatment is a wrong option. And number 4 is notify the provider immediately because there is no heart rate. So we need to inform the physician immediately. So all these 3 options are correct because the patient is having hardly any heart rate. So next one is atropine is unreliable during this Mobitz type 2 degree of heart block, and observation is not a correct option because we need to act immediately. It is an unsafe type of option. So next question is we are seeing about bradycardia, where the patient is having bradycardia with poor perfusion. So the scenario is the client's heart rate is 34, the BP is 78/40 and altered mental status. The ECG shows sinus bradycardia. Which action should the nurse take? It is a SATA type of question. So this is the particular ECG which is showing the sinus bradycardia. So the options here are administer atropine, prepare for transcutaneous pacing, and option 3 is apply oxygen, and option 4 is defibrillate the patient, and option 5 is start IV SS. So the correct options here are administer atropine, prepare for transcutaneous pacing, and apply oxygen and start IV SS. The number 1, number 2, number 3 and number 5 was correct because bradycardia is very severe to the patient. So here the definitive management is injection atropine, and if it is not acting, then we can start with transcutaneous pacing with the patients, and we need to apply oxygen as he is unconscious, his BP is very low and the airway should not be compromised, because we should start an SS to give an immediate emergency drugs to the patient, and defibrillation for this bradycardia is not a correct option. So this is being eliminated. Next we can see a question type, that is VF, ventricular fibrillation after a myocardial infarction. So the scenario here is the client post myocardial infarction suddenly collapses. The ECG shows VF, ventricular fibrillation. Which interventions are indicated? It is a SATA type of questions. Now we can see the options, that is immediate defibrillation. Next one is CPR, and third one is administer epinephrine, and fourth one is obtain cardiac enzymes, and 5 is secure airway after shock. So the correct options here are immediate defibrillation. Of course, it is correct option because the patient is having ventricular fibrillation. And next one, we are initiating the CPR. It is also a good option. And administer epinephrine. It is also a good option because sometimes after giving defibrillation and all those things, we need to support the cardiac system by giving an inotrope. So epinephrine administration is a good choice, and because it is a whole lot of process, so we need to secure the airway because we are not compromising the airway. It is also a good option. But obtaining a cardiac marker at this particular time is not that important, because we need to emphasize on the priority actions. So lab investigations can take, or we can delay it bit. So this is the type how we are answering this particular question. So next question is, we are seeing about the ECG confusion trap. What is the ECG? We are getting confused. So, which arrhythmias require immediate electrical therapy? That is defibrillation. So, it is a SATA type of question. We can see the options here. The first one is the ventricular fibrillation. The second one is pulseless ventricular tachycardia. And the third option is stable atrial fibrillation. And the fourth one is symptomatic complete heart block. And fifth option is sinus tachycardia. And the correct options here are ventricular fibrillation. Yes, ventricular fibrillation. We are giving defibrillation. It is a correct option. And pulseless ventricular tachycardia. There is no pulse in this VT, so we need to initiate the defibrillation. And symptomatic complete heart block. Yes, symptomatic complete heart block. There is no effective cardiac output and the heart rate being produced by the heart. So this is also a correct option. But in case of stable AF, there is some amount of cardiac output and the patient is very stable. So at this point of time, we are not going to give him defibrillation. And in case of sinus tachycardia, again it is not a correct option. So this shock and pacing is most important in case of this type of scenario. Next, the last question is about NCLEX priority. How we can prioritize? So the scenario is, which finding indicate a life-threatening dysarrhythmia require immediate action? So it is a SATA type of question. The options here are, the first option is chaotic ECG with no pulse, means it is a ventricular fibrillation. Yes. And second option is wide QRS tachycardia with hypotension is ventricular tachycardia. And the third option is heart rate of 48 asymptomatic. The patient is asymptomatic. And option 4 is dropped QRS complexes. Dropped QRS complexes can happen in Mobitz type 2. That is second degree heart block. And fifth option is sinus rhythm with pre-ventricular contractions. So the correct option here are, that is chaotic ECG, that is ventricular fibrillation with no pulse, and the wide QRS tachycardia, that is pulse full VT with hypotension, and a dropped Mobitz type 2 degree of heart block. These all requires immediate management. Where the rest two options, that is asymptomatic bradycardia, is not emergency, and pre-ventricular contractions are monitored, but it is not emergency. Okay. So here are the ECG of first degree heart block, second degree heart block, and the third degree heart block. And first degree heart block have we can identify, that is prolonged PR interval with each beat. Okay. And second degree heart block, the PR interval progressively prolongs from each beat to each until there is a miss of QRS complex. But in second degree heart block Mobitz type 2, the constant PR interval until there is a miss in the QRS beat. And third degree heart block, there is no relation from the P wave to the Q wave, because the P wave atrial is contracting independently and the ventricles are contracting independently. So these things we need to see, and the core NCLEX rule, what we should memorize is, if there is no pulse, we need to shock the patient, and if there is a pulse and the patient is unstable, we can cardiovert, that is, we can give cardioversion to this patient. And if there is a slow or some blocked ECG, then we need to pace the patient. Yes, these are the important things we need to keep in our mind when we are taking ECG type of questions. Okay, I hope this lecture has helped you a lot in clearing the ECG concepts. Thank you and happy learning.